Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A very warm welcome to all of the respected dignitaries and faculty who have assembled for today's program. Today's theme is key issues in OBGYN, and it's been a long-standing demand from the audience that we should have something which is a little different from the usual high-risk pregnancy series that we do. So we've had two different topics which are going to be delivered by eminent speakers for today's event. The first one is none other than Dr. Chandarlula sir, who is a legend in the field of radiology and imaging in Mumbai and of course the rest of India. Sir will be speaking to us on recent advances in gynec ultrasound. And we have Dr. Geeta Balsarkar here with us, who's the associate editor of Jogi, which is the Foxy journal. Madam is going to speak to us on improving fetal outcomes in Rh negative pregnancies. So it's a good healthy mix of obstetrics as well as general OBGYN, and we are really thankful for the faculty for sparing time from their difficult schedule at the fag end of the year when a new strain of coronavirus may come and overwhelm us all. So thank you so much for being here. And without further ado, before we start the program, I would like to express my gratitude to the AMOG's office bearers. Our president, Dr. Nandita Palshetkar, madam. Madam is the immediate past president of Foxy, the current president of AMOG's, and of course, she's also been a president of the Mumbai Society in the past. She's always supporting and encouraging for all of us juniors, and she's always helped us whenever we turn to her. She's always blessed us, and we hope that she will continue to bless us for our academic endeavors in future as well. Next slide, please. We are also thankful to our Secretary of AMOGS, Dr. Arun Nayak. Sir has been the president of the Mumbai Society in the past, equally encouraging and promoting his juniors, and we thank him for his association with us over so many years. Thank you so much, sir, for supporting us. Next slide, please. At this point, I'd like to place on record our gratitude to the ICOG office bearers, the chairperson, Dr. Mandakini Meg, and secretary, Dr. Parag Beniwale. Sir is here as one of the chairpersons, of course, for granting us ICOG credit points for all our educational and academic activities throughout the coronavirus pandemic and lockdown, including today's event. To introduce the chairpersons for today, first we have Dr. Rajendra Singh Pardeshi, sir. Sir is the vice president of AMOGS, and he is a very distinguished person as far as national politics is concerned. He's been the vice president of Foxy last year, and now he is the vice president of AMOGS. Next slide, please. As I said a little while earlier, we're privileged to have with us Dr. Parag Beniwale. Sir is the Secretary of ICOG, President of the Pune Menopause Society, National Joint Secretary of IMS from 2017 to 18, National Website Editor of Foxy for several years, 2011 to 17, peer reviewer of Jogi, Chairperson for the Young Talent Promotion Committee in the past, and Sir has several distinguished awards and prizes to his credit. Welcome, sir. Thank you so much for joining us. Next slide, please. Dr. Rohan Palshetkar is the second Joint Secretary of AMOGS and the Joint Treasurer of the Maharashtra chapter of IAG, also a Managing Committee member of MSR and MOGS. We're thankful to Rohan for joining us today. Next slide, please. And I think at this point, I should hand over to the chairpersons to take us further through the proceedings. Dr. Lulla sir has another event at 3 o'clock and he's requested to be allowed to speak first. And we are thankful to Dr. Geeta Balsarkar for accommodating us. And without further ado, I think it's time for the chairpersons to formally introduce somebody who I look forward to listening to every time I see his name on the so-called team sheet, or I can say the academic program, because for over 30 years we have watched him as students and we've learned from him so many things about OBGYN and radiology specifically. Over to the chairpersons.
Thank you, Pratik, and good afternoon all. At the outset, I would like to thank Dr. Pratik Tambe and the entire team of AMOGS for inviting me here. It's a pleasure to chair two very interesting talks by two very eminent speakers. And to introduce the first speaker, Dr. Chandarlula, who's so well known for his skills in fetal medicine and sonologist. He's a radiologist by qualification. He has numerous publications at national and international levels, and currently he heads the Department of Ultrasound at Jaslok Hospital. He's also consultant at Reliance HN Hospital, and he has been former president of IFUMB, ex-councillor AFSUMB, former editor of IFUMB Journal, ISUOG ambassador for India, and currently he's the dean of the IFUMB. It's a pleasure to present to you Dr. Chandarlula.
Thank you, Dr. Parag and Dr. Rajendra Singhi, and thanks to Dr. Pratik for inviting me here, and Dr. Nandita. Can I share my screen? Can you hear me?
Yes, Dr. Chandar.
Yes, sir, please go ahead.
Okay, so what we are going to talk about is new developments in gynec imaging and in ultrasound specifically. Okay, so can you see my screen?
Yes, sir.
Yes, sir. Okay.
Yes, sir, all good.
So basically, what we are going to talk about is at least two or three developments. One is, of course, contrast imaging in ultrasound. You know, for the last 30 years that we have been doing ultrasound, we have not used contrast. I mean, we have started using it from 2010, but at least before that, 20 years. Now, would you ever imagine doing CT without contrast? No. But we did ultrasound 20 years without contrast, and we did a fairly good job. And now it's time to do a better job. So if you can see, all neoplasms produce vasogenic endothelial growth factor that stimulates new vascularity to develop from host venules. And you can see this cartoon, how that works. So new vascular network consists of abnormal vessels, as you can see here. There's a break in the endothelium and the blood supply increases, and you get large and irregular caliber abnormal vessels, which are the hallmark of any neoplasia. And if you see ovarian malignancy, as you all know, that stage 1 5-year survival rate is very good, but beyond that we have poor survival rates. So it's very important that we pick up malignancy wherever in the body, whether it's thyroid, breast, lymph node, ovaries, uterus, early, so that we can improve the quality of life and this 5-year survival rate. And to make an attempt to look at specifically adnexial masses, we have done pretty well with regular ultrasound and color Doppler. And you can see here that the IOTA classification has allowed us to improve our sensitivity to almost 93%, and specificity is near 90%, which is not a bad thing. So here you see a multiplicity of lesions which have small papillary outgrowths. And these are the lesions which sometimes need further evaluation. Color Doppler is extremely useful. Of course, now we don't look at RI, we don't look at all the spectral indices. All we see is the amount of blood flow. So we classify into 4 categories. Category 1, where there is no blood flow. Category 2, you have minimal flow. Category 3, when you have more than like 1 or 2 vessels, so it's about moderate, we call it. And category 4, of course, a lot of vascularity. Category 3 and category 4 is specific or highly sensitive for neoplasia. Of course, if there is inflammation like pelvic inflammatory disease, there can be considerable overlaps. At most other times, the sensitivity is 90% and specificity is 92%. And it's very useful at time. Now, this is a patient with an endometrioma, which was followed up over a period of time. And you can see that cyst changing. And finally, there are solid areas and markedly increased vascular score of 3 and 4. And that is suspect for neoplasia in this growing endometrioma. And of course, the highest CA 125. So we follow some simple rules. A lesion is benign if you have a unilocular cyst and you have solid components less than 7 millimeter in size. If there is acoustic shadows like a dermoid, if there is calcification, if it's a smooth multilocular cyst with less than 10 centimeters, and of course, if there is no color Doppler flow. Any lesion is malignant if it's an irregular solid tumor, needless to say, with ascites, and if there are papillary excrescences, irregular multilobulated solid tumor more than 10 centimeter, and very high color content. So these are the two extremes. And of course, we have tumors which don't fall into these categories sometimes, and then we are in a confusion as to are they borderline tumors, are they benign or malignant, and there we need some more imaging. So we have been using MRI also, which is a very good modality, but with ultrasound, it's that much easier on the bedside by just injecting contrast and looking at the behavior of these lesions. So simple rules has a specificity again of, as I said, ultrasound 90%. And just to show a pictorial demonstration, these are characteristic benign tumors. That's a polycystic ovary, that's a simple cyst, that's a corpus luteum. This is a jelly-like material typical of hemorrhagic cyst. That's a typical endometrioma, and these are the kissing ovaries. This is the hydrosalpinx here, and this is a large mass with acoustic shadowing. You can see characteristic of a dermoid. So here, in most of these situations, there is no confusion of the diagnosis, and therefore we are in a good position. Now, there are some atypical lesions. This is, of course, an endometrioma which has bled, and there is a layering of echoes here. But sometimes many of these lesions have nodules, and these need to be evaluated. And you can see color Doppler here showing no vascularity in that nodule. So when we describe any cystic mass lesion, we use these 5 terminologies basically. It is unilocular if it is purely cystic. It is unilocular solid if it has a small nodule there. This is multilocular solid here with multiple thick septae. And the last one is solid. So it has a uniform majority of the component, more than 50% is solid. So whenever we have a kind of cystic mass, we describe it in this fashion. Then we look at papillary excrescences, and papillary excrescences are localized overgrowths of the epithelium. And as the number rises beyond 4, or if they are larger than 5 millimeter in diameter, 3 to 5 millimeter in diameter, then they are suspect and they need further evaluation. Now, this is where my subject comes in, and that is imaging with contrast in many of these tumors. So these are new technology. This is a new technology wherein which we inject 2 ml of ultrasound contrast material. This is microbubble based. You inject these microbubbles and they go into the blood vessel, and they enhance a tumor if it has lot of vascularity. So it is slightly different from CT contrast, etc. CT contrast diffuses into a tissue. This doesn't diffuse into a tissue. It only picks up the vasculature, and it tells us about the vascular behavior of the tumor. Now, before I continue, I must tell you that this is a completely safe contrast material. It is not non-nephrotoxic, and it can be used even in chronic renal failure patients where CT scan and MRI contrast cannot be used. So we can see that sometimes color Doppler is less sensitive to sensitive to slow flow and deeply located blood vessels. And I'm sure all of you who doing ultrasound know that when the mass lesion is deeper and if it has got very slow flow, then color Doppler may not show the vascularity, and that is one of the limitations of the microbubble size that we use is about 2.5 microns, and it is smaller than the RBC, and it therefore flows in through very small vascular channels, capillary channels, etc. And it can pick up vessels to the size of 25 microns, whereas color Doppler can pick up vessels above 125 microns. So that is the distinct advantage. It enhances the appearance of the vascularity in a lesion. This is just a clip. So this we inject saline and we shake it. It creates microbubbles. So, and we have special software which allows us to image these microbubbles. They destroy the microbubbles, and in the end of the examination, and tissue signals are scattered from this background noise, and this tells us the vascular pattern. Now, just one slide for the physics for you to understand that there is an arterial phase where the contrast comes in, and then it goes down, and then subsequently there is another phase here. This is called a portal venous phase, and then there is a late phase. So just to understand the three phases, and then there is washout in the venous system. So this is what we see on the graph. It's called a wash-in. There's peak enhancement, there's washout, and there is area under the curve. That means how much enhancement was there. So there's wash-in type, peak enhancement, washout time, and area under the curve. And that tells us the vascular volume, how much blood supply is there. So what we do is we examine the whole tumor to be seen. We take small parts of it wherever there are septae, papillae, etc., or where we expect the most vascular area. And we keep a 5-minute examination. A 5-minute clip is stored of total of 180 images. And here you can see there's a peak enhancement, and there's very little vascularity in a benign tumor. The area under the curve is very less, and there is washout. Whereas here, this is a malignant mass. There is massive enhancement, peak enhancement, which remains for some time, and then there is washout, and you can see that the vascular content is very, very high. So I will just quickly show you a few cases. These are, of course, this was a 30-year-old lady with menorrhagia and dysmenorrhea, and you can see that there are unilateral two complex cysts. Of course, this very much looks like a hemorrhagic cyst, and this probably could be either another hemorrhagic cyst or an endometriotic cyst. And when we inject contrast, you see the same cyst, the internal contents appear completely black because they are blood, and they do not enhance, and the periphery of the cyst enhances. So the hyperechogenicity is the enhancement, and I'll show you a clip of the same. You can see the microbubbles are coming in, and there is no enhancement of the central. So this confirms the benign nature of this lesion because there is no central enhancement and there is peripheral enhancement. Now here, this is another complex cyst in a 35-year-old known endometriosis with a small little nodule there. And of course, you can see it in different views. Color Doppler does not show vascularity. Again, it is at a depth, so we're not sure whether the vascularity is reaching there. Of course, there's adenomyosis, and therefore we inject contrast. And you will see that again, the cyst is showing no enhancement in that nodule there. And that suggests that this confirms, because there is no problem with depth imaging with microbubble based contrast. Wherever the microbubble will go, ultrasound will pick it up. And you can see that the cyst is uniformly black, and there is no enhancement in the depth of the lesion. You can see that nodule there, and there is no enhancement, suggesting that this is a safe lesion. Now, this was another lady, 15-year-old, who came with pain in the pelvis, and we could see a complex cyst with multiple nodules here. And this is a magnified image. And this looks a bit worrisome because there are irregular nodules, which are quite a lot. The vascularity is there at the periphery, but nothing in the center. And we injected contrast, and you can see that few microbubbles are coming into the nodules, not too many as compared to the periphery. And so we were quite happy that it's not enhancing too much, but at the same time, there is a little bit of enhancement, and this turned out to be a serous cystadenoma. So the enhancement is not too much there. Now, this is a 21-year-old on routine examination, beta HCG 3014, who presented with a large mass here with multiple irregular nodular shadows here. You can see that, and this is the magnified version of the same. This is with abdominal probe. You can see that we have zoomed in. Of course, it does show vascularity, so it is worrisome. And then we injected contrast here, and it's enhancing tremendously. You can see that the whole pattern is tremendously lit up and very, very bright. And you can see further the contrast coming in shortly. You will see the microbubble coming in, and it really lights up. So this is really worrisome, and the whole tumor is lighting up tremendously with the contrast. So, and you can see that this, and we follow it over a period of time. There is a timer here, so it tells us up to what time. So it is 2 minutes, and then you are starting to see washout. Now, the typical pattern of a neoplasm is that there are a lot of arteriovenous communications, large arteriovenous communications. So as compared to a benign tumor, there will be massive wash-in and quite a fast washout also. So you can see that at 2 minutes, the tumor is washing out, whereas the septa here you can see are yet showing contrast. And this was a borderline cystadenoma. So here definitely this mass lesion needs to be attended to. Again, this was a 20-year-old with multiloculated cystic tumor, and you can see that there is not much vascularity here, peripheral vascularity with thick septae. And we see this many of the times, now here we injected contrast again, and you can see the septae are going to light up with this microbubble. And color Doppler did not show the septae to be intensely vascular. But you can see that the microbubble is coming into the septae. Of course, the B mode appearance is quite worrisome. It is got multiple thick locules and septations. But at this, very quickly after injecting contrast, we can tell that this is an active tumor. There are a lot of vascularity in the septae, and therefore this needs attention. So that is the information that we get. And you can see here the frozen image. It is very, very vascular. Probably there's a clip there, and you can see that now the septae are very well highlighted with the microbubble. And this was again a borderline cystadenoma. Now, this was a 38-year-old on routine examination. This was a complex cyst here that you see here. And really speaking, this case was the most encouraging for us. There was a lot of vascularity, but it came on a routine health checkup, and it looked like an endometrioma, but this vascularity was really worrisome. And even on color Doppler, we could see a lot of vascularity. So this was really suspicious. And this is elastography. And when we do elastography, we can tell the stiffness of the tissues, whether it is hard or soft. And here, the black color denotes a hard lesion, and a blue color here denotes a hard lesion. There's a color map here. Red is soft here, blue is hard. We can change that at many times. You can make red appear hard, so just by inverting the color here. And therefore, we were all the more worried that this is a suspect lesion. And then we injected microbubble. And you can see that lesion here, which is hypoechoic and appearing just like an endometrioma, is intensely enhancing with microbubble, and so was it with color Doppler also. But this was just to confirm that there is massive enhancement in that lesion. And here again, you can see there is very early washout. Now that is an important part. So color Doppler tells us there is vascularity, but as you know, it can be a little overlapping with many other conditions. But when there is washout, when there is rapid washout, we compare all the enhancement patterns with the myometrium. And you can see that the endometrium also shows washout. That's the myometrium, which is yet showing contrast. So when the mass lesion shows washout in relationship to the myometrium, that means this is an easy way of telling us that there is early washout. And washout means neoplasia. That means there are arteriovenous shunts. And this was a granulosa cell carcinoma. And we operated her, and she comes for a regular follow-up and is extremely thankful to us for that kind of lesion. Now, this is a very elderly woman who has again come with this patient I have just done 2 days back, who incidentally came with urinary complaints, and in the adnexia we found this complex mass. And you can see that with contrast there is intense enhancement, and here there is washout happening. And you can see the curves I was talking to you about. So this is the peak enhancement, and the enhancement remains for a long time, and then there is washout, and this whole area under the curve indicates the amount of vascularity which is massive here. And this is a kind of accumulation image which tells us how much contrast is accumulating, and you can see it's becoming really bright here. So, and there is washout here, suggesting that this is definitely a neoplasm. So we have asked her to get herself evaluated. Now, this is another lady with the 50-year-old with postmenopausal bleed. And you can see that the endometrium is thickened here. This is all appearing in elastography on blue, and it has a lot of vascularity here. And you can see that this is another patient with a thickened endometrium, but which has green areas, which is suggesting it is soft. So let's see what contrast does to the uterus now. We looked at the adnexia. Now this is the uterus. You can see here the endometrium doesn't enhance as much as the myometrium. So I'll play this clip again. There's a cyst here. This is the myometrium, and that is the endometrium here. And this is useful for differentiating adenomyoma versus fibroid. So let's look at that. This is a lady here with some irregular lesions. And there is a large mass in the anterior myometrium, and it could be a fibroid, could be an adenomyoma. This is a differential diagnosis. There's small cystic areas here. The endometrium is displaced posteriorly. Now, on elastography, it appears quite stiff. It is black, but you see these white areas. These are multiple areas of cystic areas in this mass, suggesting that this could be an adenomyoma because there are a lot of soft cystic areas. And this is an MRI T2 image, again showing a lot of these vascular pools. And I've also shown a color elastography here to show you these small cystic areas here throughout the lesion. And therefore, we injected contrast, again, microbubble, and you can see that it gives a typical cobweb appearance. So there is contrast enhancing the whole lesion, but those areas of cystic areas which we saw on elastography and MRI don't enhance because these are blood pools in this mass lesion, and very different from a fibroid. And you can see the typical cobweb appearance with multiple cystic areas. So, and it pervades, the vascular tree pervades throughout the lesion. And this is a still image of the same, and that's a color Doppler image, and that's a T2 weighted image, again showing a lot of cystic areas, blood pools in that mass lesion. Now, this is there are multiple fibroids here, Provin case of multiple fibroids, and these will not enhance. So they will appear as black areas compared to the rest of the myometrium. You see the myometrium is becoming totally enhanced, whereas the fibroid don't enhance. They remain as black, so like punched out holes in these areas. So there are multiple fibroids and they will not show enhancement. So this is one quick way that we can now use to, that's a frozen image, I think. No, that's again a clip. And this is the difference of the two frozen images I have put. So that is the cobweb appearance of the adenomyoma, and this is the punched out appearance of a fibroid, which does not show any enhancement. Now, there could be some degenerating fibroids, and this is a large adnexal mass, and you can see that there is some enhancement here, but there are areas which will not enhance in this lesion. You can see fibroids will not enhance as compared to a neoplasia, which will enhance intensely, and you can see that the center part of the lesion is not enhancing. This is typical of a fibroid. Even here, you can see that the center core is not enhancing. So this is another lady with a mass in the cervix, and looks like a fibroid polyp. It has a pedicle of vascularity, and that's the vascularity here. and we can see that again that lesion is seen on B mode. Nothing remarkable about it, and it is typical of a fibroid polyp, but just to show how microbubble behaves, you can see that the vascular pedicle is showing the contrast, and that's the tumor which will show central non-enhancement. So here you can see that it will not enhance in the center, the shell will enhance, and that's the fibroid polyp. This is vis-a-vis any other polyp or any other mass lesion which will enhance intensely in the center. And you can see that it's not enhancing, and this is multiple views. This is a transverse view, sagittal view. So, and that's the pedicle you can see that's going in. This is the rest of the myometrium which is enhancing. So it's quite a specific way of looking at it, and it's quite useful, and we are trying to use it more and more. And you can see that this is just a zoomed in image of the same lesion here, which will show that there is no central enhancement of that lesion. So I think this is quite good. Then let's look at a little bit of endometrial malignancy, and this is a typical uterus, of course, with an endometrial carcinoma, with a ill-defined kind of mass there, and sometimes you were not sure. I'm sorry, this image is overlapped, but let me just see. Yeah, so it is showing some amount of vascularity. You can see that, and the borders are not well defined. You don't know where this lesion begins, where it ends, but of course, postmenopausal history with large ill-defined mass here, there is vascularity, and it is very stiff on elastography. You can see I'm pressing the uterus. The whole thing appears blue, and that soft area is the myometrium, which is probably not invaded yet, and otherwise the entire central component is hard. And let's see what happens with myometry with sonoview. Intense enhancement. Normally, as I said earlier, the endometrial doesn't enhance, but you can see that it is homogeneously enhancing with the microbubble, suggesting that this is definitely a neoplasia, and you can plan your surgery or whatever in that fashion. And there is washout. You can see that in a couple of minutes, the center part is washing out. And when we see the washout, we can see how much myometrium is involved, because the normal myometrium will not show washout. You can see at the periphery, whereas the one which is involved is showing washout. So this whole area of the myometrium is involved, and that's the endometrial carcinoma there. So, like I said earlier, the washout times and the area under the curves was significantly greater in malignancies, and leading to sensitivity estimates between 96 and 100%, and specificity between 83 and 98%. Now, this is much superior to the 90% and 93% that regular ultrasound and color Doppler was providing to us. So, we can enhance the evaluation by early detection of tumor microvascularity, and I'm sure, as many papers are now suggesting, this will become part of regular screening protocols. Now, this is just to show the different criteria. I don't wish to bore you with all this because this is all technical, but basically we are looking at time to peak, time from bolus injection to maximum. All these criteria are looked into, and you can see that the sensitivity is very, very high, and even the specificity is very high. So peak intensity is showing 100% specificity, area under the curve 90%. So this is very, encouraging that we can mix a lot of parameters, B mode, color Doppler, the elastography, and we can then look at tumor specificity. So again, here you see maximum enhancement, 96% for contrast enhanced transvaginal sonography. Specificity is 96% and 90. So different papers, area under the curve 90. And here I've just put in a couple of papers to show that people have already done a lot of work. and they have looked at different parameters. So this is a contrast enhancement related to myometrium, and you can see if it enhances earlier than the myometrium, simultaneous, later, and early plus simultaneous is more specific for malignancy, whereas if it is enhancing later, this is benign and compared to the surrounding myometrium. And the degree of enhancement also. Degree of enhancement, that is hyper enhancement, is more with malignancy, hyper and iso enhancement, and hypo enhancement, like I told you, the myomas don't enhance, is more specific for benign benign tumors. Then if you have homogeneous enhancement, is most specific for a benign lesion, but if you have heterogeneous enhancement, it is more specific for benign. The final word is not out as to how many parameters we can use, but a mix of parameters is what we are using at the moment, and probably in time to come we will have more information on this. So when do we suggest using contrast? Those with adnexal masses and at least one suggestive gray scale or Doppler parameter which is suspect for neoplasia, those who have no, those with no sonographically suggested parameter but with an elevated CA125, of course there has to be a mass, but and nothing on ultrasound to suggest otherwise. And here, of course, they have said potentially high risk women with BRCA1, BRCA2. This is specifically for the breast and can be used for the breast lesion. So I will now move to some other areas where we have some exciting new developments happening. And you can see that I just wanted to talk a little bit of deep infiltrating endometriosis. And this is a very important paper that I came across, that when you get in a woman with pain in the pelvic cavity, even with no mass lesion, but you see hemoperitoneum, this can be a precursor of deep infiltrating endometriosis. And sometimes we see this. If you see fluid with clots, as you can see here, you need to follow up these patients, because many of these patients, these are the precursor signs of deep infiltrating endometriosis, and you need to follow them up on a regular basis. And then, of course, we do this sliding sign where this is the advantage of ultrasound over MRI, where dynamic examination is possible. You move the tissues to see whether there is any adherence with the surrounding tissues, and this is not possible. This can be done in the anterior and posterior compartment, and it is only possible with ultrasound. So here again, when you push the uterus over the rectum, if it is showing movement, you can see here the rectum is moving, the uterus is moving. This suggests that there is no pouch of Douglas endometriosis or adhesions, as compared to, I think this is a case where there is, this is the anterior, you move anteriorly the abdomen, and you can see that the bowel is not stuck to the anterior myometrium. And we can then pick up, we can look at the bowel. As you can see here, this is the typical signature of the bowel, that is the serosa, the submucosa, which is hyperechoic, and the hypoechoic mucosa. And if this pattern is lost, you will see that deep infiltrating endometriosis starts from the periphery and encroaches into the bowel, and that is how it looks. So here you see, specifically here, you can see that there is a large stellate lesion which is completely destroyed the anterior, and you can see it here now. The typical three-layered pattern of the bowel is destroyed. It is intact here, intact, and when you actually move the uterus, it will not show you movement of the rectum alongside it, because it is stuck. So that is sliding sign positive. And that's a very, very useful sign for, it's a dynamic sign. And also when you do the sliding sign, the patient will complain of pain, and that is a soft marker for deep infiltrating endometriosis. And of course, you can use color Doppler. We have not used microbubble based contrast, but I think that is also a good way of, will be a good way of looking. But here with power Doppler, you can see there's intense vascularity at that side. So this is the typical Indian headdress sign. You can see that the bowel is involved, And it's a very small lesion, hardly about a centimeter. There's vascularity, and we can see how the bowel is involved here. And this is the same patient here. Now, this is with a transrectal examination. We can see the same thing transrectally. It's important to measure the lesion over a time. So you follow up. You can even do 3D imaging, as you can see here, and appreciate the intense stellate pattern of fibrosis this lesion is causing between the uterus and the bowel. And that's another view here of the same. And this is adenomyosis, you can see here with the kissing ovaries in this particular patient. And again, when we do a 3D, you can see the involvement of the bowel at that particular site. So this is very, very useful, especially for the surgeon. I think before you must do a proper preoperative mapping, see all the areas, anterior compartment, posterior compartment. And sometimes we use some tricks. We use the glove, we fill the finger with a lot of jelly, keep the probe here, and then we pass in the transducer to see the fornices better. And you can see that's the jelly here. And this allows us to see the bowel a little better because there is the jelly is allowing us to give a better view. So you can use these small tricks. And just to show you the involvement of the uterosacral ligaments here, normally we don't see the uterosacral ligaments unless there's a little bit of fluid around it, and it appears bright and echogenic here, as you can see here. But if it is involved in disease, you can see there are small hypoechoic areas here, suggesting that these are endometriotic deposits. And again here, we are doing the sliding sign, looking for tenderness, and you can see there's a lot of involvement of this sacral ligament here with these deep deposits at that particular site. And this is bladder endometriosis. You can see that there is diffuse involvement of the bladder with the ureter getting involved here. And this is specifically useful for you to plan your surgery with the urologist. Then you can look at extrapelvic endometriosis. And this is a cesarean scar site. But what's more important is in this particular patient, you can see that even subdiaphragmatic nodules, and I've seen that very, very rarely, probably the only one time that I saw it, this lady had a lot of pelvic deposits of the endometriosis. So that is interesting to see. We can also aspirate these nodules, especially if multiple surgeries have been done, patient doesn't want surgery anymore, then you can, if there is persistence of the cyst for at least 6 months, if there's benign appearance, normal CA125, of course, now with contrast, we can also inject contrast. And very simply, transabdominally, we aspirate and we inject diluted methotrexate to ablate, to kind of cause a chemical reaction in the wall. So this is something that is very easily done with ultrasound. And this was again a very interesting case of chronic endometriosis, which we were following over the years. And it suddenly came with an intense vascularity, multilocular appearance, but markedly increased vascularity. And I've shown you another case of this type earlier, where there is a lot of vascularity. And this is an endometrioid carcinoma developing in an endometriotic cyst. Now, we can also do transperineal 3D ultrasound for pelvic floor disturbances. I'm not going to talk of pelvic floor disturbances here because that's a whole huge topic, but just to show endometriotic nodules, this is urethra, that is the vagina and uterus, and that is the rectum here, and this is the levator ani on either side. And of course, we do a lot of dynamic evaluation with pelvic floor disturbances, but here you can see that even some nodules can be picked up at that site, and this is very, very low in the pelvic floor, so you may not see it with transvaginal and transrectal ultrasound sometimes, and therefore you can see this large nodule. So this is a perineal route is good sometimes to see these nodules. And again, we use also 3D coronal imaging to see the small, the endometriotic areas. The adenomyotic uterus shows typical outpouching from the endometrial margin, and that's typical of endometriosis. Of course, this lady also had multiple adenomyotic polyps. And finally, a little word on classification of myomas. This is very, very important for the endoscopic surgeon and the hysteroscopic surgeon. This is the FIGO classification, and we all use this FIGO classification now. These are the 7 types of fibroids. So you have classical submucosal class O, Class 1, which is 50% inside and less than 50% outside. Class 2 submucosal, which is more than 50% outside. 3 is just touching the endometrial cavity. 4 is myometrial fibroid, intramural. And this 5 is subserosal with less than 50% outside. Class 6 is more than 50% outside. Class 7 is subserosal. And class 2 to 5 is transmural. So it extends from the submucosa to the serosa. And just to show you a few cases, we sometimes inject saline to see it, and you can see how we measure it. We take the endometrial myometrial junction on either side, drop a line, and then we see whether 50% is inside or 50% is outside. And then we look at these fibroids and we classify. So this is class O, this is class 1, and this is majority is outside here. So class 2. And just to show you how we do it, that's a lesion in the endometrial cavity. It's seen here on coronal imaging. It's got vascularity, and then we inject saline, and you can see that the entire lesion is within the cavity. The angle that it forms with the endometrium is less than 30 degrees. Class 1 will have less than 90 degrees, and that's the endometrial myometrial junction. We plot, everything is inside the lesion, and then we can also inject sonoview if you want to highlight these lesions. So another use of contrast is, of course, to endometrial cavity lesions, and then we follow up that contrast into the fallopian tubes, and you can see there is spill on this side and there is no spill on that side. And you can use this for various other lesions. This is an endometrial polyp, very tiny polyp here. We have injected saline, and you can see. So I must suggest you to use sonohystrography with or without contrast. You can use jelly, local anesthetic jelly, or normal saline, and you can highlight these lesions very well. And these are different polyps. I'll quickly go through this. Of course, coronal 3D imaging allows you to do it without injecting saline, and you can see this is a type 2 lipomatous fibroid. You can also see that it's bright, and less than 50% is inside the cavity here. It's a very, very tiny fibroid. This is type O. Type O again, this is type 1. You can see the endometrial myometrial junction. Majority of it is outside. Type 2, majority of it is again outside. Sorry, the previous one, majority was inside. Now, why is this important? Because if you see a lesion like that, I told you earlier, transmural, going from the endometrium to the myometrium, and that's the myometrial free margin here, which is very thin. Now, this is a lesion, if you approach hysteroscopically, you can land up into repeated surgeries and sometimes into problem. Now, this was an incompletely resected fibroid, and the capsule did not collapse, and patient kept on having pain, lot of bleeding, and you see the MR appearance and the ultrasound appearance, lot of material yet left inside, and this patient was also not conceiving, and probably this approach was not appropriate. So this is a class 2 to 5 lesion, and this is not probably approachable from histography. Now, another exciting development is 4D of the endometrium with saline. So you inject saline, and you then do a 4D, and you can highlight these lesions very well. And so this is something very, very interesting. And you can see that you can also classify the fibroids here. That's a fibroid here. This is class O fibroid. This is class 2 fibroid, or class 3, I would say, just touching the endometrial cavity. That's a multiple polyps here, here also. So, and this is what we call as virtual hysteroscopy. So we inject saline and we use 4D, and we move the transducer slowly, just like you do with your hysteroscopy, and we can then see a mass lesion in the cavity there. So it's a good diagnostic tool. That's one lesion, and one lesion here. You can see here that these are 2 lesions, and it can also be done for other lesions here. You can see that there is septation here. There's the typical Asherman syndrome. That's the coronal view, which is just showing bright areas, but the moment you inject saline and do a 4D, you can see these lesions much better. How are we doing for time? Do I have more time to show some new things?
Yes, sir, please go ahead.
Okay, so one more exciting now. That was as far as gynec imaging. I will just show one exciting development which we were happy to perform in the last coming weeks, and this was a case of posterior urethral valves in a 19 to 20 week fetus. And you can see that many of these fetuses have a poor prognosis. They have severe hydronephrosis, and they have a bad outcome. So we are now on the realms of doing fetoscopic low urinary tract obstruction with laser. So this was the fetus who presented to us with almost no liquor, a keyhole appearance of the bladder, and we passed in a cystoscope here, the fetoscope through a trocar, and you can see that that's the puncture of the bladder. It is a very difficult procedure because you need to angulate and go down into the posterior urethra. And then this was the fetoscope that we could see the valves here. These are the posterior urethral valves. So this was done by a team of myself, Dr. Rasik from SRCC, and Dr. Vivek Krishnan from Cochin, and the three of us, we could manage to fulgurate the valve here, as you can see. And of course, our heart was in our hands in the coming weeks because this was the first procedure. We were not sure whether we are going to be successful or not. And that is actually the fulguration that is going on with laser. And I will show you then, that is the posterior urethra you can see now that is coming up beyond the valve. And then these are the post-operative pictures. Day one, you can see that the bladder has completely collapsed. It is thick-walled. The kidneys are a little bright, but look at this picture here. The liquor has come in, and we've got this is day one. Liquor was 8, and today, just yesterday, we have evaluated liquor has come to AFI is 12. So very, very encouraging. Last 30 years, we used to terminate these pregnancies, and if they presented late, of course, we would do postnatal correction. But this is encouraging. Now, in the last 5 minutes, I will just like to talk on elastography a little bit, because it is very useful for predicting which lesions are soft and which lesions are hard. And this is, of course, very useful in the breast. I showed you many cases in the uterus and the ovaries, but for the female patient in the breast, this can be quite useful. This female had a lump since 2 months, and you can see, of course, it looks suspect for neoplasia, but just to introduce you to the concept of elastography, it's a very simple ultrasound technique where we can do a split level imaging with B mode, and elastography gives us the stiffness of the tissues. And the moment you, just like color Doppler, when you switch on the ROI of elastography, it tells us with different color maps, if it's homogeneously red or homogeneously blue, whatever map you choose, and if the lesion is larger than the original lesion, it tells us that this is malignancy with involvement of the surrounding tissues. And you can see that this, we can also measure, just like you measure on CT, the Hounsfield units, we can measure the speed of sound in that lesion. And if the speed is high, this is called shear wave estimation. If the speed is high, this is suspect for neoplasia, and this was an invasive carcinoma. Here, the lesion is smooth margin, and it is not showing the typical intense red or blue appearance. And the measurements are showing a very low speed, 1.1 meter per second. And that's a benign fibroadenoma here. And this is another large mass here in the breast, and you can see that it's intensely blue. We can choose red or blue, whatever, so it's just to, we normally switch these colors, but then we take measurements, and all these measurements are showing 4 meters per second, 3 meters. So without injecting any contrast or any other substance, just with our ultrasound technique, we can look at the stiffness of the tissues, and this allows us to predict whether the lesion is hard. And here we are using it for the placenta. You can see that's the placenta. We are doing a 2D shear wave evaluation, and we did a small study of about 30 patients with PIH, and 19 of which had a fetal growth restriction. And when we looked at the values, normal values we found were less than 1.5 meter per second, and anything more than that was suspect for a stiff placenta. This is, of course, very, very experimental. It has no clinical value at the moment, but in time to come, you never know. It may be useful for predicting which, just like uterine artery Doppler, which placenta may show changes of extensive fibrosis at a later stage. So here, out of the normal cases, we did 30 normals and 30 PIH, and we found that a mean of 1.4 and above was 90% sensitive and about 83% specific when we were evaluating the fetuses with IUGR and PIH. And this was one such fetus with absent diastolic flow. And you can see the mean value was very high, 2.6 meters per second. This is another pregnancy. That's the placenta anterior. This is a large clot posteriorly. And you can see we just wanted to show this as a comparison. And you can see the values are as low as 0.59 meters per second, suggesting that this is a very soft lesion. Anything less than 1.4, 1.5 is soft. So that's a hematoma. So probably this technique works, and we need to evaluate these lesions further. So I think I end there. These are some of the new exciting developments that have happened with ultrasound, and I hope in the future we can use these, specifically contrast and elastography we are definitely using at the moment. It's not in any guidelines, so but there are lots and lots of papers across the globe. You can just put in contrast in ovarian malignancy, elastography in breast tumors, or anything like that, and you will get a lot of literature. I hope it was useful, and if there are any questions, would love to answer them.
Thank you, Dr. Chandarlula. It was indeed an amazing presentation. I would say that it was the magic of ultrasound when the person who's operating the machine is somebody like you. So, with so much information about the disease, only on ultrasound will be an excellent tool for us clinicians when we are managing a complicated case like this. Thank you very much. Pratik, do we have questions for Dr. Chandarlula?
There's only one question, and yes, sir, Pardeshi, sir, go ahead, sir.
Thank you, sir. Thank you, Dr. Chandarlula. See, we are blessed with Dr. Chandarlula. He has visited many times to Aurangabad Vijaya Society. Just reminded to Dr. Chandarlula, and he has given really excellent talk. And see, role of imaging in gynec cancer, because we are 90%, 95% we are doing obstetric ultrasound only. But he is a master, he is a hardcore teacher, and he is the only person who always ready for teaching, always ready. He has explained nicely the contrast of enhanced transvaginal sonography and the role of imaging in BRCA1, BRCA2. See, very excellently. Then sliding slide in endometriosis. Then the removal of cyst, coronal 3D imaging, then 4D imaging with saline, and classification of myomas with sonography, so that our management, it will be useful in management. Sir, thank you, sir. Thank you so much. Thank you.
Thank you. Thank you.
So there's only one
Yes.
question from the audience, and that's from Dr. Anita Rajoria from New Delhi. And she's asking whether there's any change in probe required or any additional cost when you do a contrast enhanced ultrasound.
No, the same probe. It's we use the same transvaginal and transabdominal probe. The software has to be there. Fortunately, most machines have the software, but you have to ask for it. They do. When you ask for it, they do quote a price, but you have to be smart enough to negotiate that. That I want this software without any additional cost. I don't think it costs too much, but it depends on how you bargain with them. And otherwise, should not cost more than $1 or $2 to have that software. So definitely there is software which is involved in, because it's microbubble based imaging, and you have to lower the mechanical index of your machine, which is easily done. It's a preset, basically.
Thank you so much, sir. It was a magnificent talk, sir.
Lulla sir, just one question. We are using methotrexate for ectopic pregnancy and those. And you told to remove the cyst. What's the mechanism behind that?
It's a chemical reaction that it's just like injecting doxycycline or any other chemical sclerosant agent. So methotrexate is just a sclerosant which we are injecting into, and there are a lot of reports which have shown successful treatment of endometriotic cysts with injection of methotrexate.
Thank you, sir.
Thank you, sir. Magnificent talk. Eye opener for all of us.
Thank you to Geeta for allowing me to speak.
No, sir, Dr. Lulla, I wanted to make only one comment that methotrexate acts on any cells that are dividing. Basically, any cells in the body that divide fast, like the placenta, methotrexate act on them. And I mean, the endometriotic cells, when they act, they cause death of those cells that multiply, and that is how they.
Actually, here you're correct. When you are injecting intramuscular, it's absorbed into the vascular system and it prevents. But when you inject directly into a tissue, it doesn't. It acts locally as a
locally it prevents multiplication of those cells,
and also acts like a sclerosant agent. Something like that.
Yeah. Endometriotic cells are those like the uterine lining which is present outside the uterus. So basically their function is to grow each cycle. So it prevents the growth.
Kind of causes damage to them. So I would suggest if you have cases which are not requiring surgery or not, you try this, because I have been quite happy with the use of this, especially in very large endometriomas, the massive ones that we see. We aspirate, we inject. And many of them have not come back only. The gynecologist has told me that the patient is recovered and she's not reporting any further cysts. So, but maybe if you do more, we'll come to know more.
Yeah, sure.
Thank you, sir. Shriman, can we have the introduction of Dr. Geeta, please? We've kept her waiting for too long.
Hello.
Pardeshi, sir.
Good afternoon, everybody. So I would like to invite Dr. Geeta Balsarkar, ma'am, and she will be addressed us on improving fetal outcome in RH negative pregnancy. So I think she doesn't need any introduction. She is professor, St. G.S. Medical College and Nauroji Wadia Maternity Hospital. She is clinical secretary, MOGS, vice president, Menopause Society, Mumbai, president, AMWI Mumbai branch, associate editor, Journal of GYN. Have undergone training for the PPIUCD program and is also the faculty member of many training programs as well. Have over 18 years of teaching experience and is actively working on FIGO-FOXY project of PPIUCD in India and recipient of prestigious Argovind Foundation for the study of fetal medicine in 2008 at St. George's Hospital, London. She is actively involved. I saw her working in Wadia. I think chordosynthesis and all these procedures. That's why we know Geeta Balsarkar and all the team, because Wadia is known to start these procedures and all those, and they are extensively work in RH negative mothers. I think she will be the right person to guide us on RH negative mother and management. Thank you so much. Over to Dr. Geeta, ma'am.
Thank you, Dr. Pardesi, for the kind introduction. Okay, I'm going to talk to you today about improving fetal outcomes in RH negative pregnancy. Though I'm sure Dr. Pardesi will agree that when over the past 10-15 years, compared to the past 10-15 years, we are seeing lesser and lesser RH negative isoimmunized pregnancy nowadays. So I'm going to talk to you a little bit about that. Though we can say that the disease burden globally is going down, especially in the developing countries, quite a few babies are affected either as stillbirth or as an isoimmunized pregnancy. Even if they survive, 24% of neonatal deaths that occur are due to RH disease, and 50% of them can present with kernicterus, and 7.2% of all RH disease affected are those who survive and then they develop kernicterus. So stillbirth and neonatal death due to RH disease is very high in South Asian countries like India, Afghanistan, Bangladesh, and these countries. And that's why every now and then we have to talk about it. So sensitize us doctors, because we can prevent this disease to a great extent. Now, if you see the Rh negative population in India, the prevalence, like you can see the maximum prevalence is in Uttaranchal, and Uttaranchal, where it is about 10.73%. This is only Rh negative population. We are not talking about isoimmunization here. Maharashtra, Karnataka, they are about 5%, which is also actually high, and Manipur and Kashmir is 8.8%, Himachal Pradesh is 10%, Rajasthan is 5.8%, Pondicherry is 6.5%. So these are the states in which we have got lot of Rh negative people, like Uttar Pradesh, Himachal Pradesh, Rajasthan, and hence therefore many centers here have developed into Rh isoimmunization and management of that. So when we talk about the pathophysiology, why does Rh isoimmunization occur? We know that there are two commonest systems for the blood group classification, which is the ABO and the rhesus system. The ABO are A, B, AB, and O, whereas the rhesus are various forms, capital C, small c, D, E, and there is no D antigen. The later represents, when you say Rh negative, it represents the absence of the D antigen. The D antigen is considered to be the most immunogenic. Therefore, when there is Rh, it is considered to be the most immunogenic factor. Actually, it is called alloimmunization. Now, when there is a Rh positive father, it depends on whether he has one copy of the Rh gene or two copy of the Rh genes. If he has one copy of the Rh gene, 50% of his children will be Rh positive, and in the Rh negative mother, these children can set up an isoimmunization. Whereas if the Rh positive father is there, all the children will be Rh positive. Therefore, it is worthwhile even studying the father's antigenicity, if we can, wherever metros, where we can, whether he has got two copies of the Rh gene or one copy of the Rh gene, which will tell us whether this baby will be 100% Rh positive or 50% Rh positive. Now, feto-maternal hemorrhage and Rh incompatibility. The amount of fetal blood which is necessary to produce Rh incompatibility varies, but they have found that as little as 0.1 ml of Rh positive cells are also responsible for isoimmunization. So studies have suggested that up to 30% of patients, these are non-responders with Rh negative blood group, but they never develop Rh incompatibility, even though they are challenged with large volumes. So we do not know exactly what makes a patient predisposed to getting Rh isoimmunized, even with very small volumes of the fetal Rh positive fetal blood. The Rh alloimmunization occurs by either one of the two mechanisms. Either this patient mother has received an incomplete blood transfusion sometime before because of an accident or because of anemia or some other reason, or it is because of feto-maternal hemorrhage between the mother and an Rh positive fetus. Now, the feto-maternal hemorrhage which may occur during pregnancy is about 10%, or during the delivery period, in the antenatal period, it is only about 10% during the entire 9 months of pregnancy. But at delivery, it is about 90%. Therefore, we have to be very, very careful at delivery about the feto-maternal hemorrhage. Notwithstanding the fetal RBCs which have been detected in the maternal blood in the 3 trimester without an apparent predisposing factor. The initial maternal response to Rh sensitization is low levels of immunoglobulins, IgM antibodies. As with any other immunization, we know the first response that comes is IgM antibodies, but they are confined to maternal circulation only. They don't enter the fetus because they are not able to cross the placental barrier. Now, within 6 weeks, sometimes it takes as much as 6 months, IgG antibodies are formed after these IgM antibodies. So the time required for the conversion of the antibodies to IgM to IgG can be sometimes as much as 6 months, depending on the dose of the immunization. But these IgG antibodies are able to cross the placenta and destroy the fetal Rh positive cells. Therefore, in many cases, the firstborns or the first pregnancies are often spared, and it is the second and subsequent pregnancies which get affected. The short enough period of the first exposure to the mother to fetal RBCs is often not sufficient to produce a significant IgG antibody response. So the first baby is a normally healthy baby, and then the second baby onwards normally gets affected. Now what happens, the sequence of in utero events, the maternal IgG which has been produced in response to the mother getting sensitized to the Rh antibodies, they cross the fetal circulation via the placenta, and once they enter the fetal circulation through the placenta, they destroy the fetal red blood cells. So first thing that occurs is fetal anemia, where the hematocrit is less than 30%. Next, the heme is formed. When we know that when the RBCs are destroyed, heme and globin get separated, heme is formed, and this heme is converted to bilirubin. Therefore, these babies have a lot of fetal hyperbilirubinemia, which the fetal liver is not able to handle. They are neurotoxic, but are effectively cleared by the placenta and metabolized by the mother. And extramedullary erythropoiesis is stimulated, and immature erythroblasts are produced. So all these effectively lead to the hemolytic disease of the newborn. When cell destruction exceeds the production, severe anemia occurs, and then there is hepatosplenomegaly because the RBCs are destroyed in the liver and the spleen, and there is also demand on the extramedullary sites to produce more RBCs. Heart failure or the congestive cardiac failure eventually occurs with ascites, edema. There is loss of fluid in the third space, pericardial effusion, which is a full-blown form of erythroblastosis fetalis, and then hydrops fetalis occurs when hematocrit falls below 15%, often results in fetal death shortly before or after birth. Now, if we find that the ratio of the male to female fetus affected, a lot of studies have been done which shows that majority of time it is a male fetus which are affected, and female fetuses happens to survive this whole things, effectively, but we can never say. So this is how the whole thing has been actually shown as a figure or a diagram in which the destruction of the fetal cells occurs when a mother is Rh negative and a father is Rh positive, and the baby conceived is a Rh positive baby. So in the entire pregnancy, this is how the entire sequence of events occur. Now, what is the risk of Rh sensitization? The risk and severity of sensitization responds with each subsequent pregnancy involving the ABO compatible fetus with Rh negative, the fetal blood being Rh positive. Suppose there is ABO incompatibility and the RBCs are destroyed. Because there is ABO incompatibility, Rh immunization sensitization does not occur. When we give prophylaxis, the risk is 16% after 2 deliveries, 1.5 to 2% occur in the entire pregnancy period, 7% within 6 months of delivery, and 7% manifest early, right from the beginning in the second pregnancy. With the prophylaxis we give, the risk drops to 0.1%. Therefore, prophylaxis are recommended to be given in pregnancy. Now, the aforementioned risk depends on 3 main factors. What is the volume of the transplacental hemorrhage or the feto-maternal hemorrhage that has occurred? 1, what is the volume? Second, what is the mother's immune response, the extent of the mother's immune response, and what amount of antibody she is going to produce? And like I said, the concurrent presence of ABO incompatibility. If there is ABO incompatibility, Rh isoimmunization will not occur or will occur to a lesser degree, because ABO incompatibility is protective for these patients, and the risk drops to 1.5 to 2% because these RBCs are destroyed because they are ABO incompatible. Rh incompatibility is only of medical concern for the ladies who are pregnant or who are planning to get pregnant in the future, and not otherwise. So when we try to manage this patient, we have to know what are the potentially sensitizing events, to be very careful and to completely cover the patient during these events. Any form of abortion, whether they are first trimester, early abortions, second trimester abortions, when we do any invasive procedures that involves the placenta or amniocentesis, chorion villus sampling, any abdominal pelvic trauma, any retroplacental bleed, antepartum hemorrhage like in placenta previa abruptio, IUFDs, multiple gestations, manual removal of the placenta after the delivery of the baby, ectopic pregnancy, cesarean delivery, all of them need cover of with the Rh antibodies. Now, other aspects of the history which we need to know is prior history of any blood transfusion and of these Rh negative females any time in their earlier period, because of any accident or because of any bowel surgery or because of any anemia or because of any other cause, and Rh blood type of the patient and the spouse, very very important, whether the spouse is having only one Rh antigen or whether their spouse is having two Rh antigens, all previous pregnancies, outcomes, interventions. If there has been a previous history of hydrops, the prognosis is very very poor and there is 90% chance of recovering. Previous administration of Rh IgGs, mechanism of injury in causing maternal trauma during pregnancy, even when we do the external cephalic version, internal podalic version, all these mechanisms also cause fetal-maternal hemorrhage, any presence of vaginal bleeding during pregnancy, any prior invasive procedures, all these we need to know when we take history of this patient. The objective of management is to prevent the Rh alloimmunization in the Rh negative unsensitized woman. If the woman is not sensitized, we have to do our full whatever best we can to prevent her sensitization, and if at all she has got sensitized, then early detection and management of fetal anemia in these women. Sensitization is determined by the indirect Coombs test, which is also called as the antibody screening. In a woman who has been previously sensitized, if we know that right from the beginning of the pregnancy, we have to keep on checking for the presence of these antibodies. So that comes to the question, what precautions we need to take during delivery to ensure that the Rh negative woman does not get or gets a full treatment. We have to talk to a neonatologist in advance and see that the neonatologist is present at delivery. We do not give strong oxytocin at delivery of the anterior shoulder to prevent severe fetal-maternal hemorrhage. If manual removal of the placenta is required, we have to do it very gently. If blood transfusion is indicated, we have to use Rh negative blood only. Nowadays, it is strictly followed, and no Rh negative patient gets Rh positive blood unless it's a real dire life-saving situation. Early clamping of the umbilical cord is indicated in these conditions. We don't wait for the mandatory 20 minutes for enough blood to get pumped into the baby. And secondly, we have to remember to leave a long length of the cord, about 15 to 20 centimeters. If they need to do exchange transfusion, they should be able to. The cord needs to be used for as for the exchange transfusion. Therefore, we need to leave a long length of the cord in these patients. We have to involve the neonatologist in all the postpartum management. We have to send the cord blood for ABO-RH typing, DCT, hemoglobin, bilirubin levels, and peripheral smear. If the fetus is also Rh negative, as is the mother, then there is no problem, no further intervention is needed. But if the fetus is Rh positive, we have to determine the dose of the Rh IgG to be given by a laboratory procedure. The 4-step laboratory procedure in very ideal conditions is we do, that is a raw-site fetal RBC screen. If there is fetal-maternal hemorrhage, if it is positive, then the acid dilution test or the Clay-Bethke test, which is commonly talked about to quantify the number of amount of RBCs in the maternal circulation, and we can estimate the volume of the fetal-maternal hemorrhage by 50% into percentage of the fetal RBCs. Or this is all done to calculate the dose of IgG to be given. And remember, we have to give this IgG within 72 hours of after delivery or the intervention. Now, these are the pictures of the positive rosette test and the negative rosette test. This is the acid dilution test. However, for all practical purposes, we don't do these tests. We clinically evaluate what could be the amount of fetal-maternal bleed and then decide. Normally we give 300 micrograms, which is enough to cover all this. But in case there has been an extra, there has been postpartum hemorrhage, manual removal of the placenta, or some other procedure which we feel that there is a large amount of maternal hemorrhage, we can add another 150 micrograms. For sensitized women, the management is guided by the presence or absence of history or the affected fetus in the previous pregnancy with severe anemia or hydrops, and the maternal antibody titers. Sensitization may be determined by doing an antibody screen using indirect Coombs test. In this pregnancy, we have to start treatment much before than the weeks of gestation in which she was affected the previous time. So this is a direct Coombs test or the direct antiglobulin test, which is used for the detection whether the woman is sensitized, and this is a indirect Coombs test. Now, what are the guidelines for the prophylaxis, giving the prophylaxis? Anti-D is an antibody against the D epitope present on the fetal RBCs to prevent the Rh negative women from sensitization. So all the fetal RBCs in the maternal circulation which has got the D epitope, that is targeted by this anti-D immunoglobulin, and it is neutralized within 72 hours of they are going into circulation to prevent the formation of the IgM antibodies now, and within 6 weeks to 6 months formation of an IgG antibody. So the anti-D immunoglobulin passive injection, it coats the D epitope and prevents the interaction of the maternal immune system with the Rh positive. So 300 microgram neutralizes about 30 ml of fetal Rh positive blood or 15 ml of the packed fetal RBCs. Now these are available in two preparations, the monoclonal and the polyclonal preparation. Monoclonal means these are highly specific antibodies against a single antigenic epitope produced by the clone of a single hybrid cells formed in the laboratory by fusion. It is specific, consistent, uniform, and very important, it is safe from the transmission of viruses and harmful proteins. Whereas polyclonal, as the name suggests, it is pooled sera from various immunized individuals made up of a mixture of antibodies with affinities for a wide range of antigenic epitope. It is difficult to manufacture in large quantities, difficult to provide in consistent batches, and there is always a chance of transmission of infection and harmful proteins. So wherever, it depends on the area where they are available. In most places polyclonal are very difficult to get, normally get monoclonal and immunoglobulin. So whatever is available we have to give. Now this is a guideline recommendation for the prophylaxis. I have compared ACOG, RCOG, FOXI, whatever are the various other guidelines, but FOXI says that we have to give to a minimum 300 micrograms within 72 hours of the delivery, and if suppose there are any sensitizing events, any surgeries, or whether if we have done any the chorion villus sampling, any amniocentesis, then we have to give anywhere between 50 to 100 micrograms, but the available dose is 150 micrograms. So mostly we give to a minimum 150 micrograms within 72 hours after that procedure, whatever is done. So everywhere they are recommended to give the 300 micrograms within 72 hours of delivery. So this is the management of the Rh negative woman. If there is no history of previous the affected fetus, then we have to obtain the AB on the Rh group of the husband. If the husband is also negative and the wife is also negative, no further testing is required. If the husband is positive, then we have to do the titers. If the antibody titer is below the critical level till 34 to 36 weeks, we can continue the pregnancy, but we have to give her the anti-D antibodies. If the antibody titer is beyond the critical week of 34 weeks, if it goes above, then immediately we can deliver the patient at 34 weeks. And if antibody titer beyond the critical level before the 34th week, then we need to test the fetus like by pre-systolic velocity of the middle cerebral artery using Doppler. And previously we used to do amniocentesis and spectrophotometry. I don't think that is required now any longer. MCA is a very good sign for telling us the fetal anemia, and ultrasound examination of the fetus, and the percutaneous umbilical cord blood sampling for hemoglobin, Rh, and for giving blood to the fetus if required. Now, if she's a Rh negative woman and she's already sensitized, previous history of affected pregnancy, we have to establish sensitization. We have to do chordosynthesis for fetal hemoglobin, Rh genotype if the father is heterozygous, or if that is not possible, if it's very early, then amniocentesis for amniotic fluid spectrophotometry and assay, and then initiate middle cerebral artery surveillance right from 18 weeks onwards. So now fetal assessment of hemolysis, amniocentesis in checking of the amount of bilirubin in the amniotic fluid, and fetal blood sampling for checking the hemoglobin level is very, very important. The middle cerebral artery has of course changed the entire course of the babies affected in the Rh isoimmunized pregnancy. It's very, very accurate, non-invasive, very importantly non-invasive, and it is a screening tool for detecting moderate to severe fetal anemia, a sensitivity of 100% 100%, and a 12% false positive rate to anemia, and it has resulted in 80% reduction in the invasive testing like amniocentesis, cordocentesis in Rh negative pregnancy, and it is a game changer. The middle cerebral artery Doppler is a game changer in Rh negative isoimmunized pregnancy. It's not useful before 18 weeks, and it is because the reticuloendothelial system is too immature to hemolyze enough cells to cause significant anemia. So significant anemia is known before 18 weeks and is not a reliable predictor of severe anemia after 35 weeks. So we should not use it after 35 weeks. So anywhere between 18 weeks and 35 weeks, it is very good to predict anemia. And if at all we are suspecting Rh isoimmunization, we should not pull the pregnancy beyond 34-35 weeks, because middle cerebral artery is not very accurate in predicting anemia after 35 weeks. And it is found to be similar or even better than the amniocentesis we used to do to detect the bilirubin in the fetal amniotic fluid. So with normal, which is normal MCA Doppler, and it is an abnormal MCA Doppler, we can see that in an abnormal MCA Doppler where there is anemia, the values are really going very high, and therefore they are very, very useful in detecting mild anemia in the fetus. So what happens when we do MC, middle cerebral artery Doppler velocimetry, and we find the unaffected or mildly affected fetus, they will have a normal middle cerebral artery. The Doppler is repeated monthly, delivery at or near term after ensuring lung maturity by giving 2 doses of steroids, and there is a very low risk of IUFD. If it is moderately affected, that is middle cerebral artery about 1.5 MOMs, instead of waiting for 4 weeks, we have to repeat every 1 to 2 weeks and deliver immediately after lung maturity, and enhancement of the lung maturity if necessary. And if it is severely affected, that is more than 1.5 MOMs, or even if it is less than that, but the baby has frank evidence of hydrops fetalis, the fetus needs help to obtain the lung maturity, and there is a very high risk of IUFD in these patients. So these are the Liley spectrophotometry charts we used to use. Actually, these used to be used before 20 years, not accurate before 26 weeks of gestation, but spectrophotometry is not used any longer. But we have to remember that MCA Doppler velocimetry and peak systolic velocity, if it is 1.5 MOM and more, then we have to do fetal blood sampling and consider intrauterine transfusions. If it is less than 1.5 MOM, we have to monitor MCA 1 to 2 weekly. Now, what is intrauterine? What do you mean by intrauterine blood transfusion? It's recommended for severe hemolytic anemia. Basically, we are trying to give RBCs from outside what is already lost, but we will not be able to help the bilirubin. Of course, the hyperbilirubinemia does not need help till the baby is born, because it can be transported across the placenta, and the maternal excretion can occur, typically carried out between 18 to 35 weeks of gestation. If for some reason the baby is small and we are not able to tap the umbilical cord, we can leave some RBCs intraperitoneal also. That was how it has actually started. Intraperitoneal transfusions used to be given. Rh negative blood packed cells with hematocrit of 80% is used, and the amount to be transfused, like we calculate like this, the gestational age minus 20 into 10, where the gestational age is more than 20 weeks of gestation. And this is how the whole thing is done. With the help of ultrasound machine, we identify the entry of the umbilical cord into the placenta, and that is the site of blood transfusion through the umbilical vein in the placenta. If for some reason we are not able to find, or if it is very posterior, we can tap a free loop of the cord also, and blood can be given into that very slowly. The Rh negative, sensitized Rh negative women, the postpartum, the baby should be admitted in the NICU, and urgent exchange blood transfusion is indicated in moderate to severely affected neonates. At the same time, they will have to give in phototherapy to excrete the bilirubin that they have produced. What are the special fetomaternal risk states? Like if there is abortion, there is a 5% chance of sensitization. So at the least, they give 50 micrograms. If you are able to procure 50 micrograms, then it is okay. But 150 microgram is easily available and should be given at the least. Invasive procedures, 11% chance of sensitization, 300 micrograms is recommended. Antepartum hemorrhage, 300 micrograms stat, and to be repeated 12 weeks later if the pregnancy lasts that long. And external cephalic version or any other procedure that is done, 6% chance of sensitization, 300 micrograms is the dosage. And if there is a delivery with fetal-maternal hemorrhage or postpartum hemorrhage, the normal amount of blood that enters the maternal circulation is 0.5 ml, and therefore we give 300 micrograms that will neutralize 30 ml of the whole blood. Management is guided by the estimated volume of fetal-maternal hemorrhage, and the dose of RH-IgG is to be given after sensitization is at least 20 microgram per ml of the fetal RBCs. So if 300 is good enough to cover most of these patients, if at all you feel she needs a little more, you could give another 150 or another 300 whenever required. Now, what are the recent advances? Non-invasive fetal RHD genotyping from fetal cell-free DNA in the maternal circulation. This is a very important step. This is another non-invasive step. Just the mother's blood has to be collected, and like just as we know that NIPT, it is used to detect the fetal RH genotyping, and point of care test, that is rapid testing for determining the RH status, and the low 50 microgram preparation of RH IgG for use following the first trimester abortions, but it is not available everywhere, available in certain cities. And the concept of partial D and weak D antigens usually test positive, but they can also form the RH antibodies, and therefore some of these patients whom we really don't know can get sensitized. So the take home message is that every woman of childbearing age should know her ABO and RH typing, and this should be done right at the first contact. The first time a patient visits your clinic, you must know her ABO and RH, and obtain the ABO and RH type for husband of woman if they are RH negative, and a single postpartum dose of 300 micrograms may be inadequate in severe cases of fetal-maternal hemorrhage. So we may have to give another 150 or 300 micrograms as and when it is required. The cost of immunoglobulin was actually very high initially, 5 to 10 years before, but now it is still even better. Many patients are now affording, and the lack of resources to adequately investigate and monitor the fetus in utero, therefore you may need to transfer the patient to a tertiary care center, and the low turnout for antenatal clinics and the missed cases, very important, and poor documentation of prior sensitizing events, because sometimes we know that she has lost a baby to RH isoimmunization prior, but there is no documentation, or we don't know at what weeks of gestation she lost the baby. So if we know that, we are in a better position to handle this pregnancy. Therefore I request that whenever there is any patient who is, even if there is a bad outcome, please give us an entire timeline of the incident that has happened to be able to help us the next pregnancy. The discharge card should exactly say that at what age she came, when was her first antenatal registration, when was her ABO and RH done, and whether the husband was investigated, and at what gestational age she came with antibodies, or what were her presenting complaint, did she directly present with high drops, because that is going to give a bad outcome every time, and we need to intervene exactly 4 to 6 weeks before the gestation that the previous pregnancy got affected. Therefore we need to have a proper documentation of the sensitizing event, and please give a proper discharge card, and we should know what exactly happened the previous time, and case notes should not be lost, because they are very helpful the next pregnancy. So the recommendation are advocacy for partnership by government and NGOs to help subsidize the cost of immunoglobulins. Even in government setup, the patient has to buy her own immunoglobulins. It's not that they are always available in the hospital. Special insurance cover for RH negative women to ensure the ease of procurement when needed, and the creation of the special flora RH negative people, where potential RH negative spouses can be met. If a RH negative woman gets married to a RH negative man, it will prevent sensitization and further affection of the babies. So concluding, RH alloimmunization, that is a correct name for it. Alloimmunization is a real problem, and we need to have real efforts to mitigate its impact, because in our country, maternal childbirth is not covered under insurance or by the government. Hence, it's a huge cost for the couple. Therefore, though its incidence is actually reduced very dramatically, yet even one couple is enough to have very bad consequence of hemolytic disease of the newborn. And great advances have been made in the detection and the management of the condition. The game changer is a middle cerebral artery Doppler, but many of our RH negative women, we can give an happy obstetric outcome. Thank you very much.
Thank you, Dr. Geeta. It was really excellent talk. She has explained very nicely because Rh negative mother still is a problem of Rh negative mother because RPL is very common if not treated, and if not treated, so even perinatal morbidity, mortality is also increased. So she has explained Rh negative mother and fetal hemorrhage, Rosette test, direct Cumtex, indirect Cumtex, and mainly the anti-D prophylaxis guidelines. She has explained very nicely. And in the management also, all explained, and the role of MCA Doppler also. So thank you, doctor. Thank you. So it was very nice, Gita. Thank you so much.
Thank you, sir. Thank you.
Geeta, it was indeed a brilliant presentation. Just a quick question. Traditionally, all of us are doing serum bilirubin test on the cord blood. But the pediatricians say that if the ICT is negative, if you immunize the mother on time antenatally, then there's no value of doing bilirubin. What is your take on this?
Yes, if the baby is not immunized, then there is, if this is the first baby, or if the baby is not immunized, the mother is not yet immunized, there is no sort of sense in doing the cord bilirubin. Cord bilirubin, however, even if you do it, it may not exactly corroborate or tell you which baby will need phototherapy and how the bilirubin is going to rise. We will not exactly come to know unless the baby lives 4-5 days, and then we are able. The bilirubin normally, even in physiological jaundice, comes on the 5th day of life. It doesn't come before that. So it comes on the 5th day of life in physiological jaundice. In Rh isoimmunized, as the hemolysis occurs, it may take a little longer time. It will actually appear in the 4th or the 5th day and will progressively appear. So the cord hemoglobin, cord bilirubin may not exactly corroborate with the amount of jaundice in the newborn.
Absolutely. So this is a very important take-home message for all of us that
you can send it. I mean, I'm not
but
saying
then
you
no
don't
advantage.
send it.
No advantage of
you cannot corroborate it. You cannot say this baby will be fine and cannot develop jaundice, or you cannot say this baby will develop. That is a clinical.
Absolutely. So it would make sense only if the on the say 4th or 5th day when you find the bilirubin levels rising, that is the time you actually start thinking of some kind of an intervention. Definitely.
Or if you are sure that the baby is isoimmunized, then they can start prophylactically on phototherapy also, so that they don't the bilirubin level don't rise. So single surface or double surface or whatever suits them.
Thank you, Gita.
Thank you. Thank you.
And Dr. Gita, a history of 2 or 3 abortions in Rh negative mother. So not received anti-D prophylaxis. So in the next pregnancy, how will you advise anti-D prophylaxis?
I will do titers, sir. I will do if the Coombs test I will do, and during the pregnancy, and if the titers are nil, then she will be followed up like any other patient. But suppose the titers are positive, that means she is isoimmunized, and then she has to be followed like that.
Is there any role of giving empirically in the 16 weeks and after 28 weeks?
No. Immunoglobulins, you are asking. Immunoglobulins are very costly, sir. They are very, very costly. And if we surely know that the previous baby was isoimmunized and lost, and that too around 18 to 20 weeks of gestation, where we cannot exactly tap the cord. So Dr. Mandakini has done some studies in which she has given immunoglobulins to the umbilical cord, or even the mother is given immunoglobulins, but it cost about 36,000 per injection, and most patients are not able to afford that, and there is no convincing sort of results that we can see. In a non-immunized patient, we should definitely not give anything. We have to just wait and watch. The first pregnancy, normally nothing happens and they manage to get away. Like I said, we cannot exactly say which patient will get immunized and which patient will not. So we have to just wait and watch and do the titers every time they follow up.
As Parag told about the cord blood bilirubin, is there any relation of cord blood bilirubin and after 5 days means jaundice?
No, that's what I'm saying, sir.
So
Even when
you
cord
can
blood bilirubin is normal, because of ABO incompatibility, also the baby can get jaundice. Because of RH incompatibility, also they can get jaundice. Just by doing cord bilirubin, we cannot exactly predict which baby will need phototherapy treatment and which baby will not need. We can
Exactly.
do it, but we still have to follow the baby, and that is fourth, fifth day, we still have to send the bilirubin, and it is more or less a clinical decision.
That is correct, but can we predict cord blood bilirubin?
No.
No, we can.
No.
Thank you. Thank you.
Thank you, sir.
Thank you so much, respected chairpersons. We had a fantastic session today. We had two very eminent speakers in the shape of Dr. Chandarlulla and Dr. Geeta Balsarkar. Over 400 people were logged in spite of it being a busy weekday afternoon. And there are no further questions from the audience. So, with your permission, I will present the official vote of thanks for today's event as the convener. I'd like to place on record my gratitude to the AMOG's office bearers, our esteemed President, Dr. Nandita Palchetkar, our Secretary, Dr. Arun Nayak. For the ICOG credit points, we have to thank our esteemed Chairperson of ICOG, Dr. Mandakini Megh, and of course, we need to also thank the Secretary of ICOG, Dr. Parag Biniwale, who is also a chairperson here today. Thank you so much, sir. Thank you to Dr. Rajendra Singh Pardeshi, our Vice President of AMOGS, and Dr. Rohan Palchetkar, our Joint Secretary, for gracing the occasion. And as I said, we had two fantastic speakers. Dr. Lulla's talk was actually an eye-opener. Those of us who are bored watching the same obstetric talks day in, day out for the past several months, it came as a very pleasant and wonderful education. We hope to have more such wonderful talks by eminent faculty in the future. And I wish all of you a lovely afternoon and evening ahead. Thank you so much for joining us. Goodbye. God bless. Thank you so much. Bye.
Goodbye. 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 Thank you. Thank you, Pratik and team. Pratik is doing excellent work. Thank you.
Yes, absolutely.
Parag.
Hello.
Geeta.
Thank you, Subhush, Rimon, Science Integra, and Bharat Serums and Vaccines as well.